Welcome to this CME on Pathophysiology and Diagnosis of Warm Autoimmune Hemolytic Anemia. I am Bruno Fattizzo, along with Irina Murakhovskaya, and we are thrilled to be sharing this educational material today. Here are our disclosures.
So autoimmune hemolytic anemia refers to antibody-mediated red cell destruction with or without complement involvement. And it has an incidence of 1 to 3 per 100,000 per year and a prevalence of 17 per 100,000 people. Autoimmune hemolytic anemia can be classified by antibody characteristics. Warm autoimmune hemolytic anemia is the most common form and is seen in 60 to 70% of cases. The pathogenic antibody is IgG with possible complement fixation depending on the subtype of the antibody. The optimal temperature of reaction in warm autoimmune hemolytic anemia is a core body temperature, which is 37 degrees centigrade. The antibodies are generally reacting against the Rh system, and direct antiglobulin test is generally positive for IgG or IgG with complement if there was complement fixation. In about 20 to 25% of cases, we see cold agglutinin disease or cold autoimmune hemolytic anemia, where the pathogenic antibody is IgM, which is very good complement fixator. The optimal range for reaction for this antibody is 4 degrees of centigrade. The antibody is generally directed against the I antigen system, and the direct Coombs is positive for complement. Less common is mixed autoimmune hemolytic anemia. Mixed autoimmune hemolytic anemia refers to warm autoimmune hemolytic anemia with presence of clinically significant cold agglutinin. So you will have both warm IgG and a cold IgM with reactivity at 4 degrees and 37 degrees. And in a direct antiglobulin test, you will see IgG as well as high titer cold IgM. And finally, the least common subtype of autoimmune hemolytic anemia is paroxysmal cold hemoglobinuria. Here, the antibody is IgG, which is able to fix complement and bind and react to the red cells at 4 degrees centigrade and hemolysis at the core body temperature at 37 degrees centigrade. The antibody is directed against the P antigen, and the test is to diagnosis is called Downert-Landsteiner test. This is a much less common subtype of autoimmune hemolytic anemia, which predominantly is seen in children in the setting of viral infections. The pathogenesis of autoimmune hemolytic anemia consists of the breakdown of central and peripheral tolerance, which is due to either genetic factors, such as congenital syndromes and immunodeficiencies, with most common etiologies being autoimmune lymphoproliferative syndrome, or ALPS, common variable immune deficiency, IgA deficiency, or a Kabuki syndrome, which is characterized by mutations in KDM6A and KMT2D. In addition, you can have immune dysregulation, such as seen in autoimmune diseases, including lupus, inflammatory bowel disease, and sarcoid, as well as rheumatoid arthritis, or in a setting of hematopoietic and solid organ transplantation, or with use of certain medications, including immune checkpoint inhibitors. Environmental factors, such as acquired lymphoproliferative disorders or viral infections, also contribute to development of autoimmune hemolytic anemia, with CLL, non-Hodgkin's lymphoma, being the most common, with CLL being the most common cause of lymphoproliferative disorders associated with warm autoimmune hemolytic anemia, and non-Hodgkin's lymphoma and Hodgkin's disease being common, fairly less common. Viral infections, including HIV, hepatitis B and C, parvovirus, and more recently, COVID-19 infection, have been associated with autoimmune hemolytic anemia development as well. So to summarize, in about 50% of cases, the autoimmune hemolytic anemia is idiopathic, meaning that there is no known associated condition that can potentially be accounted for the pathogenesis. In about 20% of cases, autoimmune hemolytic anemia is associated with lymphoproliferative disorders, including CLL in 5 to 10% of cases. Waldenstrom's macroglobulinemia was seen in 16% in this particular study. Non-Hodgkin's lymphoma seen in about 2% of cases, but angioimmunoblastic T-cell lymphoma is actually a common subtype among the non-Hodgkin's lymphomas that is associated with hemolytic anemia. And autoimmune hemolytic anemia is seen in the context of Hodgkin's disease in about 1 to 2% of cases. About 20% are seen in association of autoimmune disorders with lupus, antiphospholipid syndrome, and ulcerative colitis being the most common. And about 10% of cases are other etiologies, such as infections, drug-induced autoimmune hemolytic anemia, solid tumors, including ovarian dermoid cysts, hematopoietic and solid organ transplant, and pregnancy. So, Bruno, how do you diagnose autoimmune hemolytic anemia?
The diagnosis of autoimmune hemolytic anemia starts with patient presentation and with the patient complaining specific symptoms regarding anemia and hemolysis. Most symptoms are generic and not really specific, including fatigue, asthenia, shortness of breath, worsening of a previous cardiac discomfort or other cardiac symptoms and signs, and other are more specific for hemolysis, like dark urine, jaundice due to increased bilirubin levels. Starting on these symptoms and patient presentation, we perform some laboratory tests. First, the complete blood count, which would show decreased hemoglobin level, which is the definition of anemia. And then we also check for hemolytic markers, which include lactate dehydrogenase levels, bilirubin, particularly unconjugated bilirubin, the levels of reticulocytes, which should be reported as absolute number and not only as the percentage of red blood cells, and also decrease the levels of haptoglobin, which is a scavenger for hemoglobin and which would become reduced during active hemolysis. The degree of alteration of these hemolytic markers may be different across the various forms of autoimmune hemolytic anemia. In particular, patients with warm autoimmune hemolytic anemia generally have a more acute presentation because hemolysis occurs at 37 degrees, which is body temperature. So active hemolysis may destroy a huge number of red blood cells and lead to very severe anemia with less than 6 grams per deciliter hemoglobin level in most of the patients at presentation. Usually, LDH levels are particularly increased during the active phase of the disease and at onset, whilst symptoms like acrocyanosis or Raynaud phenomena are less frequent in patients with warm autoimmune hemolytic anemia and more typical of patients with cold agglutinin disease. Additional signs of symptoms like splenomegaly or lymph node enlargements or signs of skin reactions or urticaria, angioedema, arthralgia may be present if associated conditions are present together with autoimmune hemolytic anemia and should raise the suspect of an associated condition because, as we saw in the previous slides, autoimmune hemolytic anemia may be secondary to associated conditions in more than 50% of cases. So the diagnosis of autoimmune hemolytic anemia follows a long flow chart, as you can see in this slide, which begins with patient signs and symptoms and also with a careful anamnesis, patient history, medication history, because we saw that also medications may be associated with the development of autoimmune hemolytic anemia, but also with the family and personal history, particularly from the very beginning of a patient life, because sometimes patients presenting with acute hemolysis in adulthood may still have signs of chronic hemolysis, and if correctly investigated, may have features of congenital hemolytic anemias. So it is very important to take into account even congenital forms in the differential diagnosis. Then we focus on the hemolytic nature of the anemia by evaluating the single markers of hemolysis, reticulocytes, unconjugated bilirubinia, bilirubin, reduced aptoglobin, and the increased LDH. But as we can see on the right part of the slide, in the green boxes, all of these hemolytic markers have some confounders. Because, for example, unconjugated hyperbilirubinemia may be observed even during Gilbert syndrome, or may be observed even in patients with liver cirrhosis or liver disease. The same can be said for LDH. Increased LDH may be observed during various diseases, including muscle problems, muscle injuries, liver disease, but also, for example, myocardial infarction or pneumonia or other hypoxia conditions. So all of these markers should be assessed in the clinical context to exclude the possible confounders. The next step would be the direct antiglobulin test, which is the pivotal test to diagnose autoimmune hemolytic anemia. It is generally performed with polyspecific antisera in most of laboratories, which means that in the same tube you would put anti-IgG and anti-complement antisera to detect immunoglobulin G or complement fractions directly adherent on the surface of patients' erythrocytes. This is called direct antiglobulin test or Coombs test, direct Coombs test, because it evaluates the presence of the autoantibodies directly adherent on patients, so autologous erythrocytes. This test is performed by using patients' erythrocyte, putting them inside a tube containing anti-IgG or anti-complement fraction antisera, and the positivity of this polyspecific direct antiglobulin test would give the diagnosis of autoimmune hemolytic anemia. But it doesn't tell us whether it is a warm form or a cold form or a mixed form that we saw in the previous classification of autoimmune hemolytic anemia. So it is pivotal to also perform the direct antiglobulin test with monospecific antisera, which means that in different tubes we would assess patients' erythrocytes together with anti-IgG antisera, anti-complement fraction, anti-IgM, anti-IgA immunoglobulin, and so on, so that we will be able to unravel the exact positivity of the direct antiglobulin test. In particular, in patients with warm autoimmune hemolytic anemia, we would have a direct antiglobulin test positive for IgG only, or in about 30% of cases, a direct antiglobulin test positive for IgG and complement at low titer. In addition, we can perform the indirect antiglobulin test, which is called the indirect Coombs test. This test doesn't evaluate the patient's erythrocytes, but evaluates patient serum against donors' erythrocytes to assess whether in patient serum we have circulating autoantibodies or alloantibodies. So the indirect antiglobulin test is very important to unravel the presence of alloantibodies that may be particularly harmful when you need to transfuse your patients, because they may lead to transfusion reactions. Also, it can be used to evaluate patients' autoantibodies and to assess the specificity of these autoantibodies. So to unravel whether these autoantibodies are directed against RHA system or I system, I antigens, P antigens, and so on. So these are the two tests that are pivotal for the diagnosis of autoimmune hemolytic anemia, and the monospecific DAT for the diagnosis of warm autoimmune hemolytic anemia. If the direct antiglobulin test with monospecific antisera is positive and allows the diagnosis, we are happy with the diagnosis of warm AHA. But it may happen that we have a small number of autoantibodies, or maybe that these autoantibodies have low affinity for our erythrocytes, for patients' erythrocytes. In these cases, we may have a negative direct antiglobulin test with the tube test. So we need to move on, usually this is done at reference laboratories, with more sensitive techniques, like, for example, low saline solutions, washing, cytofluorimetry, and other techniques that may allow the detection of very small amounts of IgG autoantibodies, even in patients with direct antiglobulin test negative autoimmune hemolytic anemia. Even if we increase the sensitivity of the test, up to 10% of patients may remain negative at the direct antiglobulin test. In this case, we need to exclude all the other forms of autoimmune hemolytic anemia, and the diagnosis is made after a first trial of steroid therapy. So we call it the ex juvantibus diagnosis after response to steroid treatment. Next to the diagnosis, the parameters of the complete blood counts, as well as of hemolytic parameters at diagnosis of autoimmune hemolytic anemia, may give us hints about the severity of the disease, but also on the probability that these patients would relapse after the first line of treatment. And this is based on a large retrospective analysis of more than 300 patients, where it was shown that the levels of hemoglobin at diagnosis is the most important, the most relevant predictor of outcome in patients with autoimmune hemolytic anemia, including patients with warm AHA. In particular, it was estimated that the risk of relapse is significantly higher in patients with less than 6 grams per deciliter hemoglobin, more than 3 times higher than patients with hemoglobin comprised between 8 and 10, and with patients with higher levels of hemoglobin. In addition, it was observed that patients with warm autoimmune hemolytic anemia that also activated complement and showed a direct antiglobulin test positive for both IgG and complement at low titer are at higher risk of relapse. These patients usually also show a more severe disease at diagnosis, so they require higher attention, particularly during the treatment phase, where which we will talk later. So to conclude, the clinical severity of warm autoimmune hemolytic anemia is influenced by autoantibody class, ability of antibodies to activate complement, and adequacy of bone marrow compensatory response. The direct antiglobulin test, particularly with monospecific antisera, is the cornerstone of diagnosis, but can be negative in up to 10% of cases, requiring more sensitive methods, reference laboratories, and also the use of ex juvantibus diagnosis through steroid treatment. The identification of secondary etiologies is essential, as therapy can be different in these cases.